and all our social media platforms, as well as our PrideTT mobile app available on Android to iOS. Today's event is entitled eduQUEER Health Fair, hosted by myself, Makeisa. Today, we will have various presentations on different health ailments such as NCDs, women's health, HIV, COVID, and much more. This event is all day, so we hope that you tune into all segments. Just some community. During the month of Pride 2021, Trinidad and Tobago Trans Coalition is hosting a chat room on HIV awareness and education Mondays to Fridays from 5 p.m. All information is available on our social media platforms. PrideTT has collaborated with Scotiabank to expand the generation gap and launch a community-run mentorship program for persons between the ages of 17 to 25. Please visit our website for more information. So good morning and welcome, guys. As I said today, I will be your host. I'm Makeisa. I'm 25 years old and I'm so excited to be a part of this. Healthcare is such important to everyone, and we know this is something everybody wanted and to have more information on and gain education. It's my great pleasure to warmly welcome and assure you that today is full of excitement as we've lined up something fruitful, engaging, and really edifying. So without further ado, I'd like to introduce our first presentation done by Dr. Arianne Brown. Dr. Arianne Brown is a public health professional with much experience in the National HIV and AIDS program, COVID-19 response, and with a background in virology and research. I hand over to Dr. Brown.
Good morning, everyone.
Good morning, Dr. Brown Jordan.
I'm just about to share my screen so you guys can see the presentation.
Hi, good morning. So welcome to all the listeners present and those who may even listen to this later on. This content is initially being presented at the PrideTT eduQUEER Health Day. So today I'm going to talk to you about HIV and COVID-19.
I think we lost volume. Mr. Hanamji, Dr. Jordan Brown, I think we lost volume.
All right.
Co-infection that can happen and vaccination.
So let me just
All right, I think we're hearing the audio now. So perhaps we may need to restart that session.
Okay. So today I'm going to talk to you about HIV and COVID-19. It's a presentation mostly based on the scientific research that has been done and published. And I really hope that you're able to pick up something from it. I know the audience may be diverse. So firstly, there's so much on the topic that we could potentially discuss regarding HIV and COVID-19. But what we're going to do is focus mainly on the viruses, co-infection that can happen, and vaccination. I am a virologist and a research scientist, and so much of what I provide to you today would be regarding the viruses themselves and information on vaccines for persons living with HIV. So firstly, HIV, right? So many of us are well aware of HIV. It has been the popular one before COVID-19. And so HIV, it's an RNA retrovirus that affects the immune system of the human host. It has the ability to insert its genetic material into the DNA of the infected host cells. It primarily targets the immune system cells called CD4 T cells. And so if left untreated, it can lead to AIDS, which is a syndrome characterized by the body not being able to defend itself. Regarding origins, HIV is linked to the chimpanzee version of the virus called simian immunodeficiency virus, SIV, and its emergence is thought to have been due to blood exposures from hunter interactions with chimpanzees and butchered for wild meat. So, of course, prior to COVID-19, HIV had been the popular virus. There continues to be national targets, very ambitious targets for HIV treatment and care all over the world, because the ultimate aim then, and it will continue to be, to stop the virus from circulating. So what I'm going to do is try to do a side-by-side comparison of the two. So we're going to go on to SARS-CoV-2. So the virus is spread via the respiratory route, primarily by droplets or contact with contaminated surfaces and fomites, as well as by aerosols formation during invasive respiratory procedures. But in essence, the virus is an RNA virus from the group coronaviruses, and you can have a respiratory syndrome, or it can also present as being asymptomatic in some individuals. In terms of the origins, coronaviruses do occur naturally and can cause disease in mammals and birds. Animal reservoirs exist for multiple viruses, and coronavirus is just another one of those. All right, so there are a number of viruses that are linked to insect vectors and animals. So there's Ebola, there's dengue virus, rabies virus as well, HIV as previously mentioned. Right, so these are all considered at some point zoonotic. So what I would not go on to dispute is the origins of the SARS-CoV-2 outbreak. It's still being debated and investigated. However, these viruses generally they do occur naturally. Sorry, the coronaviruses do occur naturally. Even in some populations in parts of Asia where the interaction with certain animal groups, when they do check the immune status of some of those individuals, they do find antibodies against coronaviruses, because they generally exist. And then side by side, I just found it's interesting to look at the two viruses side by side for their commonalities and their differences. Of course, they have similarities in structure and some aspects of modality, how they operate, but in essence, they're very different. Both viruses are RNA type viruses, as mentioned before, and so they house RNA genomes. So those squiggly lines within the center of the virus or the viron is their RNA genome. They provide the information about creating a new virus or new virion when replicating. and they both have the surface glycoproteins, which are those red portions that are sticking out of the particles. So they have their glycoproteins. For SARS-CoV-2, we're well aware now of the S protein or the spike protein on the surface. And for HIV, we have GP120, GP41 as the glycoprotein that sort of interacts with the host cell. Those are responsible for specific attachment to receptors in order to enter host cells, the human host cells. HIV, on the other hand, has, if you look at it, you realize it has a couple other components inside. So it has its own proteins in some instances to allow it to perform some of the functions independently. So viruses are very dependent on the human host cell. Some more so DNA viruses are less dependent, but RNA viruses tend to be more dependent on the host proteins as well. But HIV has its proteins that allows it to, you know, get itself integrated and replicated. So it's partly assisted by the host. SARS-CoV-2 is more dependent on the host proteins. So HIV has proteases and reverse transcriptase, integrase, etc., to allow it to perform its duties and to rapidly infect. So I'm just gonna touch a bit on the spike protein for the coronavirus. You know, the spike protein has a specific conformation. So yes, it's found on the surface of the viron, but all those spikes are very specific and they allow the virus to attach to the host cell receptor in a very specific manner. So this here is just a 3D simulation of the molecular conformation of the spike glycoprotein. And you know, it allows scientists to just have a better understanding of, you know, how the spike protein attaches to the receptors. So you can, you know, have a look at the receptor binding domain. And you can also use it to determine how potential drugs or therapeutic drugs may interact with the spike protein in order to block it from binding to the receptor and so on. So, you know, our immune system mainly comes into contact because that is the spikes are the outermost layer of the virus. It's what our immune system mainly comes into contact with. And it goes on to develop antibodies based on those spike proteins on the surface. And vaccines as well are also modeled after the spike protein because it is the immunogenic portion of the virus. Just a little note, though, you know, because as we can see there, the protein folding is so specific. And so any mutation that occurs can potentially lead to disruption or change in that specificity of the folding, and then the inability of antibodies that the body may have developed through infection or through vaccination, you know, it can change significantly to prevent the antibodies from recognizing the spike protein, and so it evades, you know, the immune system attack. Yes. So next slide. So I just wanted to touch a bit on the mechanism for replication, you know, just to highlight the differences between the two. So the SARS-CoV-2 virus, it attaches, the main mechanism really involves firstly attaching to the receptors, which will allow for internalization or entry of the virus into the host cells. So, and that is done by the ACE2 receptor on the surface of the cell. So that receptor is very present within lung tissue and parts of the respiratory tract, and even in other organs across the body as well. So once there's that internalization, then there's uncoating of the virus so that the genetic material becomes exposed, and it allows for the genetic material to be able to show the message or the instructions for producing the necessary proteins to allow the virus to replicate and so on. Right, so as you can see here, the genetic material is transcribed into various portions of messenger RNAs to make those various proteins that are necessary for the virus. And of course, we have the S protein there as well. It then moves on to being translated into those proteins. So it uses the host Golgi apparatus and other enzymes to allow for its replication, and then eventually it's encapsulated and released out into the out of the cell, so it can go and infect other cells. So regarding the HIV virus now, what we have is a mechanism very similar for entry into the cell, where it has the receptor and the surface glycoprotein attaches to that receptor. It allows internalization or entry into the cell, and then, of course, as mentioned previously, HIV has its own unique set of proteins which allows it to do even more. So it has its reverse transcriptase, which allows it to make DNA, which can then get into the host cell. The nucleus in particular is the aim for the HIV virus. So once that reverse transcriptase works and produces a portion of DNA, so the actual HIV genome is integrated by another enzyme which is available again in the HIV virus, integrase. It then goes and inserts itself into the human or the host cell genome as a provirus, as you can see here in the nucleus, right? And then it goes through, the transcription, etc., to produce its RNA and as well as its other necessary proteins, and then it gets, it's sent out from the cell to go and infect other cells. But the main thing is the integration that occurs within the nucleus, within the DNA of the host cell, is the main challenge with the HIV and the development of HIV vaccines, as well as therapeutics that can completely clear the virus from the system. It's because the virus is able to integrate into its host DNA. So we're going to move on from that virology portion now. So an estimated 22% of the world's population has at least one health condition that increases their risk of developing severe COVID. So one such condition, of course, of interest in particular is with HIV infection. So we have seen the data and the news where hospitalizations and deaths are reported in persons mostly with underlying health conditions. There are instances where persons without conditions have contracted the virus and developed severe disease and may have even passed away. So it's not exclusive, but it does happen mostly in persons with health conditions. So just a bit about HIV again and its role with COVID-19 infection. So because HIV is, it affects the CD4 T helper cells. So HIV is known to deplete the immune system of the host. And those cells are critical for the body's response to any other infections coming in. Right? So these cells are quite popular. They're also known as T helper cells, T helper lymphocytes. So they're type of white blood cells that serve as key initiators or activators of various immune functions. They include, the B cells, which produce antibodies and need to fight off infection. The cytokine T cells, which kill cells carrying infectious agents, macrophages, and so on. So the helper T cells are very important for overall immune response, which is why HIV leads to an immunodeficiency status. So what's good though is HIV antiretroviral therapy is very important for keeping HIV viral load low and undetectable. And so once there is that therapy, then HIV is kept sufficiently low to allow the immune system to be adequately restored. Right, so the T cells would be able to function as they should once the HIV viral load is regulated. So what happens in the case of HIV and SARS-CoV-2 co-infection? There are diverse views on, on the outcomes and so on, but it really depends on, how these studies were conducted, where they were done as well. So, and whether they looked at it at a population level or hospital level. So what we do know though is countries with better control of the HIV infection and where people know their status and where treatment seeking is fairly high, they tended to see better outcomes for persons with co-infection. Generally, though, publications have highlighted either none to only slight increased risk of severe infection and death when there is HIV co-infection with SARS-CoV-2. So HIV infection without ART, right? So without ART and co-infection with SARS-CoV-2 worsens the COVID-19 progression and outcome. So, our previous slide, emphasize why it's important to be on ART so that it controls the viral load and it frees up the body to perform its function, the T cells to perform its functions. So alternatively, HIV COVID-19 patients who were on ART, regimens and who continue to receive proper therapy were generally less affected by SARS-CoV-2 and had better outcomes. So the key message here is, being on ART. On a micro level though, because HIV infection naturally leads to T cell dysfunction and exhaustion. Once there's co-infection with SARS-CoV-2, there's even greater dysfunction of these T cells. And so, it highlights the importance of having controlled low and undetectable HIV viral loads. This is a study publication that was done based on data in the UK. So, of course, other comorbidities can increase the risk of severe illness and death regarding COVID-19 infection. And so NCDs, such as obesity, poorly controlled diabetes, high blood pressure, and more severe chronic diseases as well, such as heart disease, certain stages of cancer, asthma, lupus, psoriasis, arthritis, smoking. Some of these have raised the risk of death slightly, as highlighted by this publication. So a good health status, whether you have HIV infection or without, is important for better outcomes, generally with regards to SARS-CoV-2 infection. The main thing, of course, that was found as a significant factor contributing to severe disease was age, which is what we have been seeing occurring across the world, because, of course, with increased age, you also have the chance of having other NCDs and so on. So this study, or this repository of data, also found that persons with current AIDS-defining illnesses were 3 times more likely to suffer severe illnesses than severe illness from COVID-19 than persons who had HIV but who did not have AIDS, right? So again, it shows the importance of having your viral load regulated. Several studies have also showed that a low CD4 cell count increases the risk of severe outcomes, even without underlying health conditions. So the same UK registry, however, found that people with CD4 counts below 200 had a higher risk of death and prolonged hospitalization, and that than persons with a CD4 count above 200. I just wanted to spend a little time on the ARV drugs, because it does come up as a question sometimes about why aren't these drugs being used for treatment against SARS-CoV-2. So, outrightly, ART does not protect from COVID-19 disease acquisition, progression, or death, right? In the early 2020, there were a couple studies done, controlled with drugs to determine, and they continue to do different studies regarding drug therapies. But in terms of the ART drugs, they wanted to see if they would be effective against in persons with COVID-19 infection. But they had not been, because the mechanism, of course, for the antiretroviral medications are different. And as we saw when we did the side-by-side comparison of SARS-CoV-2 and COVID-19, because they're different, the drug therapies, again, will have to be quite specific. So most of the ART medications are either reverse transcriptase inhibitors, integrase inhibitors, entry inhibitors against CD4 receptor binding, and protease inhibitors. And as we discussed before, some of these proteins here are specific to the HIV virus, the viron, and they were actually inside the virus particle when we looked at it. SARS-CoV-2, on the other hand, does not have those proteins. Well, the SARS-CoV-2 actually uses the host proteins to perform some of its functions, right? So the drugs have mechanisms that are specifically for HIV retroviruses, and you know, we would need to design therapeutics that are more broad spectrum or specific for SARS-CoV-2. And of course, you know, researchers continue to work tirelessly to develop such, but it's quite a challenge indeed. So I wanted to cover SARS-CoV-2 vaccines for a bit. So the vaccines generally have been in existence for many years, and most of us are very familiar with our childhood vaccines. And you know, there are also vaccines that we've had, or some of us have had, depending on the type of work that you do, against more chronic or deadly infections, like such as rabies and so on. So SARS-CoV-2 vaccines are a therapeutic tool, just like the others, intended to protect populations against the virus. The spike protein of the virus is responsible for the viral attachment, and that is the main antigenic portion that is used for vaccine development, and as we touched on earlier as well. And vaccines are fairly specific in design, using the genetic information from the virus target. So just a little more on that, you know, the specific design using the genetic material of the previously identified strains of the virus makes the vaccine very unique and specific to those strains. So that's why we are starting to see now a couple of challenges with the vaccine covering or having coverage against the variants that are emerging. So the variants may then go on to evade the developed host immunity as their, you know, spike protein structure may be slightly different, and so the antibodies may not be able to bind to it or recognize it. Vaccines are very important for persons with various immunocompromised communities, especially persons with non-communicable disease conditions. And here in Trinidad and Tobago, you know, we are conducting a priority vaccine drive for persons who are at increased risk of becoming infected with the virus, or persons who are with an increased risk of having a poorer outcome. Those are the persons that are being targeted at the moment for the vaccine drive. The aim is to have those persons obtain some degree of immunity against the virus. In the event that they do come into contact with it, they will have a better chance of fighting, a better chance of survival, and definitely it would reduce any health seeking if they do become infected. So their chance of developing symptoms and severe disease will be much reduced. So priority vaccination, though, which is what we're doing, it gives a fighting chance to persons who are more vulnerable. And this is especially important where there are challenges for the country to reach herd immunity. So because of, you know, the limited vaccines that are available to us here and, you know, across other developing countries, it's important to prioritize because we're not going to have sufficient coverage of the population to allow for herd immunity, to allow those people to be protected because of, you know, the reduced number of the reduced circulation of the virus. So recommendations were made this year, though, around March, I think, so this is in Europe, so the European HIV Medicines Association and the AIDS Clinical Society. And so on, they started to recommend that persons with CD4 counts below 350 should be prioritized for COVID-19 vaccination. And the aim really is because, and based on the data that has come forward, persons who, who were less able to manage, who weren't managing their HIV viral load as well. So those persons who weren't managing it well, they were more vulnerable. And persons who have good regulation of their viral loads, they seem to be fine. So they're really persons with with CD4 counts below 350 to be prioritized for vaccination. I wanted to cover the vaccine types a little bit, because persons are concerned about, which vaccine they're getting, which one they think might be better, and so on. But I just want to touch on the differences in the vaccines. And as I go on, we would end up looking at, which one is more recommended for persons with HIV. So with the vaccine types, we have messenger RNA or mRNA vaccines, viral vector vaccines, and inactivated and immunogenic protein vaccines. So mRNA or messenger RNA vaccines, they tell the body, or they tell the host cells to make this spike protein. So it's this genetic information basically, but at the messenger RNA level, it's a message that's being sent, and it tells the body to make this spike protein. And so the body then recognizes this spike protein as foreign and triggers an immune response. So that's the mechanism used for Pfizer and Moderna vaccines, which we don't really have much access to here as yet. In terms of the viral vector vaccines, these that are used, they really utilize a mechanism where there is a harmless virus, usually adenovirus. It's the body. It's not harmful to the human body, so they use that as a carrier, and it carries the genetic information for the spike protein. And the body is then able to read that and produce the spike protein again, so that the immune system can detect it as foreign and trigger an immune response. So that is the methodology used for the Oxford AstraZeneca vaccine, which we have access to here in Trinidad and Tobago. And then there's inactivated vaccines, which is what Sinopharm is of here. So the inactivated vaccine is the actual SARS-CoV-2 virus particles, but it has been inactivated, as in it cannot function as it normally would. It's people tend to use the word killed, so it's just weakened, but it still has that, that spike protein conformation.
We lost out again. Volume down, video frozen.
Hi, Michael, you hear me?
You said what?
We're hearing you.
Yes.
But the video is It's frozen right now.
Right, yeah, okay. All right. Okay,
All
look,
right,
it's coming back up.
Yeah.
Mm.
I think my internet may have dropped there for a little bit.
Oh, okay.
Yeah.
All right.
Guys, I just want to remind you that we're going to enjoy Dr. Brown's presentation and form our questions, and after we will have a discussion.
Okay, awesome.
So let me switch over to the slides so I can continue. It seems to. In the meantime, Makeisa, are there any questions I could probably take in the meantime because I'm trying to get the, it's just a couple left. All right, actually, I think I have them now.
Okay. Mm.
Do you have any questions, Michael?
Not at the moment. So far, so good.
So, Dr. Brown,
All right, so I'm going to.
as you were talking about the vaccine types, right? With the harmless virus in contrast to the inactivated, is that why we're seeing like persons experiencing less adverse effects, or because of the type of virus vaccine it is? Sorry.
So y'all seeing my screen again?
Yes.
All right, great. So yeah, so you're asking, yeah, based on the vaccine type or the mechanism in which it uses, if persons have more severe reaction to the vaccine than not?
Yeah, as in relation
Was that?
with
Oh. Yes, yes. So the viral vector vaccine and the mRNA vaccine, because it's actually instructing the body to actually make spike protein for the body to then recognize it as foreign. So it takes a little more toll on the body as opposed to an inactivated vaccine, which is just there. It's not producing any copies of itself. It's not producing any spike protein. And so for that reason, the vaccine-related symptoms are much less. Yeah. So I just have 2 more slides. So I'll just go through them quickly. Oh, and let me just cover the immunogenic protein vaccine. So those are related to they're vaccines that are developed using the protein itself rather than RNA or genetic information, right? So the immunogenic protein vaccine uses something that's highly immunogenic. So when the body sees it, it's like, oh my goodness, what is this? And so a toxin is very immunogenic, and usually that's what's used. And so the spike protein is attached to the toxin, and so that becomes your vaccine. So when that's put into the body recognizes it instantly as foreign and starts to build the immune system, the immune response. And so the Sombrano vaccine out of Cuba uses that methodology. There's some others as well in the works using that same methodology. Right, so I'm just going to focus on the two that we have here mostly, which is AstraZeneca and Sinopharm. So in a cohort of persons on ART and with high CD4 counts, as in above 500, so these are persons with, who have their HIV well regulated. The AstraZeneca vaccine provided the same strength of immune response as compared to people without HIV. And there was also no difference in the common vaccine side effects, including fevers, headaches, soreness at the injection site, chills, joint pains, and so on. So AstraZeneca, it normally gives you a lot more side effects, as we just mentioned previously, but there was no difference noticed with regards to this cohort. I think these were two studies, so this cohort of persons and persons without HIV. And then regarding Sinopharm, there are limited number of studies and case studies of PLHIV having had the Sinopharm vaccine. However, the WHO recommends persons being included in vaccine trials, and some ministries of health have already taken the decision to use the Sinopharm vaccine to vaccinate their populations. It's recommended because it's non-replicating, so it doesn't provide any extra strain to the body, and it's inactive. And that mechanism it provides some sort of immune protection, which is desired. And so my key takeaway messages to you guys are to take note that the viruses are unique, so they both have specific molecular characteristics. I mean, and all viruses have specific characteristics that allow them to behave differently with regards to host infection, pathogenesis, how the body responds, and so on. Health conditions can increase your risk of severe COVID-19. So any chronic infection and any non-communicable diseases, infectious diseases as well, can increase the risk. But art regimens are critical, and good overall health is critical to have better outcomes with regards to COVID-19 infection, as well as co-infection when persons live with HIV. And of course, get vaccinated once it becomes available to you. Vaccinations will allow the body to build a natural defense against the virus, and is particularly important for those at risk of poorer outcomes. So I just want to thank you guys. Sorry about the little glitch there, but thank you guys for listening, and I hope that you have some questions or comments that you might want to share. And I just want to give special thanks to the organizers of the event, my colleagues at Ministry of Health, as well as the University of the West Indies. Thank you, guys.
Thank you, Dr. Arianne Brown Jordan. Thank you. Greatly appreciate.
No problem.
Thank you, Dr. Brown Jordan. It was very insightful. Like, the information given has broadened my knowledge. It has placed everything together, and we really appreciate this presentation you have brought forward to us. Most of my questions were answered in the last slide, so I love that. But one thing that I wanted for us is if you can go in more detail on herd immunity, because a lot of persons understand that we want to gain herd immunity, but they don't really have like a concrete understanding of what herd immunity is and how it can help in the COVID-19 pandemic in Trinidad.
Okay, well, herd immunity is something that is gained when a sufficient number of your population becomes either infected or vaccinated. So herd immunity is when you developed antibodies, whether from primary infection, as you said, with infection, or from vaccination, and it needs to be at a level of about 70%, and only when it gets there will you be able to see the virus, that whichever virus it is we're talking about, you start seeing the virus circulating much less. We are challenged though with COVID. I'm trying to turn on my camera so you guys can see me. Okay, great. So we are challenged with COVID because we have variants emerging.
Yes.
Right, so we have variants emerging, and some of those variants are escaping the immunity that we have built either through vaccination or through infection. And so, the levels of circulation of those strains, so that those variant strains are, going right back up. And so, even though we have vaccines now, the vaccine companies and the authorities are already looking at, the fact that we might have to get booster vaccines, probably vaccines every year, just as we do for influenza, to ensure that we keep circulation of the variants down. So it's going to be quite complex in trying to reach herd immunity when you have a situation where variants are constantly emerging. So the healthcare workers and researchers have quite a bit of work cut out for them. But in some countries with herd immunity, for example, if in Trinidad we had from the start, we had, when vaccines were being distributed, if there was enough to vaccinate, 70 to 100% of the population, and people were willing as well. And, we went down that road and, people got their vaccine, then, the country would have had this level of herd immunity that prevented circulation. So it means persons who may have been vulnerable would not have even had to get a vaccine.
Correct.
The children as well, the children who can't get vaccines, they would have been covered as well through the herd immunity. So there are going to be a lot of challenges once we don't have vaccine access and production and all that being at levels where it needs to be. So it's going to be a hard fight. Of course, the ideal is to have a drug therapy. And I'm pretty sure, there's a lot, actually there is a lot of research going on with drug therapies, but it's that in itself has its challenges, and it's going to take some time before we have something coming out. Yeah.
Okay. Thank you for that.
Dr. Jordan.
Yes.
Hi. In terms of the rapid mutations or development of various strains, speak to the importance or necessity to maintain health protection protocols, even though one has received both vaccines, one or both vaccines. If you can say something on that. Because I know we kind of let our guards down once we start to receive vaccine and even assume herd immunity. Yeah?
Correct. Yes. Yeah. So those same variants, which we just mentioned, could evade the immune system. So it means even though I've been vaccinated or I have had infection before and I have antibodies, I could still get infected with variants. Sometimes I can still get infected with a strain that's similar, And so if I am infected, and even though, I may not be symptomatic, I may not end up with severe disease, I may not end up in the hospital, but even though I am asymptomatic or with very little symptoms, I still have, there's still the opportunity for me to spread the virus to somebody who has not received a vaccine, who hasn't had it before, who's not covered. In many instances, because we are accustomed to vaccines providing coverage for us to, we get our vaccine and we're good for life, yellow fever, say, okay, well, I got my yellow fever shot, I'm vaccinated, I'm not going to get yellow fever, so we are accustomed to that. But it works a little differently regarding the SARS-CoV-2 because of the fact that there are variants that can emerge, and so we really need to still wear our masks. We still need to wash our hands. We still need to watch our distance right now, especially as the level of coverage for vaccines is not as it should be as yet.
Thank you.
So to that we can say that our basic known standard precaution of washing hands is still very important.
Yeah, exactly. Yes.
What can you say? Sorry.
Go ahead.
What can you say to persons who may have some varying levels of apprehension towards taking the vaccine for various reasons, be it religious or fear, whatever? What can you say to them to convince or alleviate their fears and anxieties?
Yeah, so I mean, there's a lot of fear out there, but really and truly, there's also a lot of information. I think people have been receiving so much on the good side, the good aspects, as well as stuff that might be misinformation, and so it creates a lot of confusion in someone's mind. And I mean, my recommendation, and it will continue to be my recommendation, is always try to go to reliable sources of information regarding vaccinations. There's a wealth of, bodies and authorities that provide good information and accurate information. And even when there are questions, even when you have questions, to seek answers from people who are in the field and who can provide you with the best information. So even coming out of what I have just shared with you, you've seen that the whole vaccination drive is not 100%. It's not entirely adequate, and so yeah, when healthcare professionals share information like that, people think, well, why am I even doing this? The questions continue to arise, but it's important to understand the broader picture and in terms of the public health perspective of what is trying to be achieved and attained, because that's important as well. So vaccine hesitancy is real, but I'll always encourage people to seek the correct information, and nobody can force you to go. So seek the best information from the better sources, and try not to get too swayed by the wonderful animated and people are very good at presentations as well. So I've seen some really good misinformation presentations. They brought across really, really well. But be careful, because yes, it can create this conflict in your mind. And so, yeah, I just have to tell you to, seek the best information, because I don't want to force it up on anyone. Everyone has to make the decision for themselves, what they're going to do about vaccinations. But also talk to, friends and colleagues and relatives who've had experiences, who've probably been infected with COVID-19, who's had, loved ones who have passed on. you know, when we hear stories, the real stories from real people, we come to realize how serious the situation can be. So you have to know for yourself, you know, what you need and what you need to do for your family as well, because it's not just about you, you're also trying to protect your families. And with that, I will pause there.
Thank you. I know we have a sector of the population who may not tune into informative media, you know, the media that's not focused on putting out credible information. But I'm also concerned as to, because of the volume of information coming from both camps, credible sources and non-credible sources, propagandas and so forth, how does one distinguish from the two, and how can we reach a wider percentage of those who may not tune into information media, let's call it information media, who don't read, who don't listen to documentaries and what have you?
You're asking me a very hard question, Michael. You know, because we're talking about human behavior, you know, we're moving into human behavior. So, you know, it's very difficult to, you know, to bend and control. But, you know, I think some people like to latch on to things that may not be true, or may seem or sound more exciting. So I could even go to the, you know, the origins of, you know, SARS-CoV-2 and, you know, when did this happen? So, you know, a lot of people are thinking, well, it emerged in the market, perhaps the bushmeat that they were selling there, you know, may have been contaminated and it spread to others and so on and so on. But that doesn't sound exciting. So people want to hear about the lab leak theory, you know, maybe
somebody created this.
Yes, exactly. So people like to hear the thing that is more exciting.
Like the
yes, exactly. Exactly. So I mean, it's difficult. It really is a difficult question, you know, and a challenge for us to try to deliver the right information and point people in the right directions, because I think at some point people always like to swing back to what sounds more exciting and juicy.
True.
Like, or even like what is more available, because most of the time the misinformation is more available than the information, and I just
loud.
think like what we're
loud
doing
bombardment.
Today,
and loud bombardment, louder and more bombarding.
Yep, that's it. So as Dr. Brown Jordan rightly said, like a lot of people ask me about the virus and ask me about the vaccine, and I will never impose what I think about it, because that is something important to understand as well. Even healthcare professionals have their opinions. So I think as healthcare professionals, we need to put out as much information and education, probably get it in the misinformation theories, like get it in how they present it. Like, I just think if we could put out more education that it's there and it's on a level that everyone could understand, because people still gonna go for what is easily accessible, and misinformation is very accessible. Like, a lot of people want to go and read all the studies, they find it too long, they just want to read the abstract. So I think like this is like something good. We could start podcasts, we could start something that we could put out as much credible information in relation with the misinformation. But I think when it comes to vaccination, that like somebody shouldn't come to you to make their decision. Yes, you'll give your opinion, you'll give an objective opinion, but in some cases, some healthcare professionals, they give subjective opinions because not all healthcare professionals are for vaccinations. So we need to remember that as well.
Right. Okay. Yes, and you're right. I mean, there has been a louder voice of miscommunication, and you know, is why we've seen you know, the CDC and WHO and even our Ministry of Health. We've seen like
Yes.
they've invested so much in communications now, and they're making sure they push on as many platforms as possible.
Yeah, I have to comment on Twitter. They post like 5 times a day. I love them. I read it every day. I really have
Yeah.
to comment.
And we even have you know, directors and different personnel from other departments and units within the ministry actually going on to radio programs, doing TV programs and so on, just so that we can attempt to have the bigger voice. It really is a challenge.
Yes. Anybody have any more questions?
Makeisa, if I could just interject for a quick moment.
No problem.
So I'm so happy you all came around this issue in the conversation. And because it highlights why this year at PrideTT, we really put an emphasis on the health fair. And for those who may not know, well, Makeisa would know this, but we actually replaced the parade with a vaccinade. So every event, we are encouraging our members and allies to consider getting vaccinated and to continue to follow the protocols, because there are two reasons for this. One is everything that we do at PrideTT is data driven. So every year we run a community needs assessment, and we were able to survey over 230 community members, and only 42% of them had yet been vaccinated. But hopefully more will be, because nearly 60% of them said that they want to join the vaccine need. So that is very encouraging, that they want to get vaccinated. What was unfortunate, very tragic, was that nearly 80% of them actually lost someone due to COVID-19. So it's very close to home. To your point, Dr. Brown, you know, in terms of how people, you know, have to consider this as a very serious concern and to think about the ultimate possibility. And if the vaccine can help you to stave that off, then, you know, consider it and have it done. So the other reason that we are committed to this type of education is, of course, historically, the queer community has been the victims of a lot of misinformation about healthcare. I mean, we were talking yesterday with someone who was very close to the HIV epidemic. And she was talking about the fact that in the early days, I mean, these are things we forget sometimes, people did not even want to share the same room with someone who had a certain disease, especially HIV. They didn't want to shake their hands, etc. So misinformation has really done a disservice to many vulnerable groups, in particular the queer community. And we want to do our part to work with professionals like yourself to ensure that the right information gets out there. So just wanted to add those bits of color into the conversation, and thank you all for raising these important issues.
Thank you. Anybody has any more questions?
I think I've exhausted the questions in my mind. Thank you, Dr. Jordan.
No problem. That was a really good interjection just prior. you know, I really like the fact that you guys are, you know, pushing and vaccinate. That's great. Because we have to do our part, you know, to help the situation and to see, you know, help the country back to a path of normalcy rather than, you know, turn people away from. So I really like that.
Okay, so if anyone doesn't have any more questions, Dr. Arianne Brown Jordan, we'd like to thank you for joining us today. It was quite informative and edifying. We appreciate all the information and the time you took to present to us. We would like to thank everyone, all our invited guests, everybody that came on. We'd like to thank everybody that joined us. And we'll see you all at 11:30 for our next segment. Thank you.
No problem.
Thank
Thanks for having me.
Thank you, Ms.
I wish
Edwards.
you guys the best for the rest of the day.
It was nice meeting you all.
Thank you. Blessings, everyone.
Okay.
Take care. Be safe.
Bye.
Happy Pride, everyone. Bye-bye.